Hello friends. In my previous videos, I have been talking to you about female urethral microanatomy vis-a-vis the mechanical function of the female urethra. And I'll also be making some references to why this part of structure is important to be conserved during female urethral reconstruction. So I first talked about the basic design of female urethra. Then I talked about the first part of female urethra, the intramural part and its mechanics. Now I'm talking about understanding the mid-urethra of the female. The mid-urethra is this 20%, this 20%, and this 20%. Mid-proximal and mid-distal. And this is the area which I'm going to speak about. Not the one here and not the one here. And we'll study this urethra from inside to outside in different layers. The first inner layer of the urethra is the urethral mucosa. And this mucosa is thrown into longitudinal mucosal folds which are more prominent towards the bladder neck, right? And these longitudinal folds make the urethral lumen like a star. The epithelium of this mucous membrane is different at different levels. At the lowermost level, lowermost I mean from urethral meatus, external urethral meatus to inwards, it is stratified squamous epithelium. Then for a while it is pseudo-stratified squamous epithelium, and as you go toward the bladder neck, it becomes the transitional epithelium. So the characteristics of the epithelium is such, and with the advancing age of the patient, more and more urethra becomes stratified squamous. And I'll touch upon in a video separately about the changes of the urethra as per the age. Now over this epithelium, these holes, and these holes are the ducts or the pituitary glands. These holes are more in number in the distalmost part of the urethra. As you go upwards, they are scanty, but there are no holes in the upper part, right? These are opening of periurethral ducts. Over this epithelium is the covering of urethral mucus. Now this urethral mucus, as you will see by the change in the color grading, the mucus is more in the distal part of the urethra and becomes lesser and lesser as you go towards the bladder neck. And this mucus has a purpose. It physically, by the viscosity, resists upward movement of pathogens, and as well as immunologically, it reduces the virulence of these pathogens. It just has some immunoglobulins inside it, and by them, it reduces the bacterial virulence. It lubricates the urethra also, allows the resistance-free egress of urine, but it is more useful for prevention of infection. Then we move to the next layer outside the mucous layer, and that is submucosal layer. When you focus on the submucosa outwards, there are two venous plexuses, one towards the external orifice and one towards the bladder neck. These are round vessels, and they are called as proximal venous plexus and distal venous plexus. But the one which is in the middle urethra is longitudinally placed vessels, and this is called middle longitudinal venous plexus. So please appreciate the difference in the appearance of these blood vessels. Look at the cross section here, and look at the cross section here, and look at the cross section here. Now this venous plexus is hormone sensitive. In a lady who has prominence of hormones in her active reproductive life, These vessels are very supple and they can dilate and they can collapse, and this can fill up like this can engorge like this, and this engorgement occludes the urethra. See, empty here and see closed here, just because of the engorgement of submucosal venous plexus. And you should know that this cushion generated closure is responsible for 30% of urethral occlusive pressure at rest. When women age and hormone influence is withdrawn, the submucosal venous plexus becomes attenuated, and this capability of occluding the urethra becomes less and much less. Then is the third layer outside, which is the longitudinal smooth muscle of urethra. Now, if you see this in a coronal view, this is the bladder and this is the urethra. From all around in the bladder, the longitudinal muscles dropping down, descending down, and then covering over the urethra, and each fiber comes from the detrusor into the urethra and gets inserted into the distal urethra. You can imagine this arrangement as if this is a small bottle, and into bottle somebody has packed in lot of sticks from all around. So lots of peripheral fibers for detrusor, they converge into the urethra like a bouquet of flower, and then they get all concentrated into the urethra, and the fiber traverses the entire urethral length to get inserted into the distal 20% of urethra, which is a collagenous distal urethra. There is no muscle in the distal most part of the urethra. Now, this is the arrangement of the muscle longitudinally. If you see these muscles in a sagittal view, you will notice that most of the muscles are placed in the anterior part of the urethra, like that. And in the posterior part of the urethra, there are hardly any, very limited. If you see urethra in a cross section, you notice anteriorly lot of muscle bulk. I'm talking of longitudinal smooth muscles. And as you come posteriorly, they become thinner and thinner. Again, you see in the coronal view, this is the muscular part of the urethra, and there's a more bulk towards the bladder neck. As it comes down towards the lower part of the urethra, become thinner and thinner and thinner, and then they get inserted into the collagenous urethra, attached, firmly anchored into the collagenous urethra. If you see this in a sagittal view, I told you that major bulk of the longitudinal muscle is anteriorly located, and then it comes like this, becomes thinner and thinner and thinner, and inserted here in the collagenous part. As you come towards the posterior part, and this is sagittal view, most posterior part, in the most posterior part, if you cut a sharp, accurate sagittal section, there is no longitudinal muscle in the midline. What you have in the midline? You have in the midline, this is the superficial trigone, which is traversing the entire urethral length and getting inserted into the collagenous distal urethra. Right to the midline, there is no longitudinal muscle. Inner longitudinal muscle is anteriorly placed. Posteriorly, you have the continuation of superficial trigone, and then the deep trigone finishes much higher up in the intramural part of the urethra. If you see this convergence of longitudinal fibers in the bladder neck, this is the trigone here by green, and this is the convergence of longitudinal muscle fibers into the bladder neck. In the anterior part, the longitudinal muscle fibers are more thick, and as you come towards the bladder, posterior part of the bladder neck, they become thinner and thinner. If you cut a cross section at the level of bladder neck, and that's the point I was making, urethra, the more fibers are located in the anterior part of the urethra, less lateral, very little posteriorly. Right to the midline is the trigone, and this trigone is more firm, fibrous kind of thing, and longitudinal bundles get attached here. If you draw another cross section low down, you will see this becomes thinner. And if you take another section low down, you will notice that this becomes thinner. If you see this in a sagittal animation again, this is the mucosa, submucosa, and this is the superficial trigone coming up to the distal urethra, and that's a deep trigone. And this here, the vaginal wall posteriorly, vaginal muscle and vaginal mucosa. In the lowermost part, I would call 2/3, this urethra gets fused with the vagina by a dense connective tissue. This is almost inseparable. Urethra is a part of intervaginal wall, to be more honest, in that part. But upper 1/3, it is separable and free. And then there are some glands which are present here. We'll talk about the glands separately. Now this is the longitudinal muscle I was talking about. More bulk placed anteriorly and then traversing laterally, and as you come in the right midline, nothing. Only trigone. Right? Now what is the function of this longitudinal smooth muscle? This is the reference point of the external urinary meatus, and this white is the collagenous distal 20% of urethra, no muscle. And I told you longitudinal muscles are inserted into this distal collagenous ring. And posteriorly, this trigone is inserted into the distal collagenous ring. Imagine if this muscle is to contract and pull upwards. If it is pulled upwards, this smooth curve will become straight like this, and this orifice will be pulled up. See again, at rest, and the moment it contracts, it pulls the urethral ring because it is inserted here, and it shortens the urethra, it funnels the urethral, right? Both things. It shortens the urethra as well as opens the bladder neck. Anteriorly, this part is done by longitudinal muscle, and posteriorly, this function is done by the trigone, the superficial trigone. Now we come to the another layer, the circular smooth muscle of urethra. And if you see this in a coronal section, this is the longitudinal muscle in blue, and then there are rings of the muscle fibers, circular smooth muscle. Now, as you come down towards the lower part of urethra, the number of rings become lesser, right? The circular layer as such is thinner than the longitudinal layer. Whatever it is more present towards the bladder neck and less towards the distal urethra. If you see the sagittal view, although this is called circular fiber muscle, it is not in the entire circle around the bladder neck. It is like a U. It begins from one side, goes, and then comes on this side and finishes here. Each loop is like this. And posteriorly, they are attached to the superficial trigonal extension. So the raphe of the superficial trigone, which is traversing in the middle of the urethra posteriorly, circular fibers come and they get attached. I refer you to the same animation that I showed you earlier. This was the inner longitudinal muscle, right? And here is the circular muscle fibers. You will notice more bulk here, and as you come down, becomes less, and very scanty here. And remember, no smooth muscle extends into the distal 20% of the urethra. They just finish where above. Now, something complex to understand. It has been observed that the nerve supply of inner longitudinal muscle and outer circular muscle is same. When a nerve is stimulated, both contract. So they act synergistically to occlude the urethra, and you will understand this by this animation. This is the open urethral lumen here, right? And this is the inner longitudinal muscle in a relaxed state. And around this is the outer circular muscle in a relaxed state. Okay. When the nerve is stimulated, what happens is that this longitudinal muscle fibers contract from both sides. In a former pictures, I showed you one function of longitudinal smooth muscle is pull up. When it is pulled up from the bladder side, so it pulls up the external urethral orifice, shorten the urethra, straighten the bladder neck. It is when it is pulled from one side. Here, by neural stimulation, it contracts from both sides, up and down. And as it contracts from both sides, it becomes more bulky, right? It contracts with more volume. And the smooth muscles around them, they also contract. So what is happening is that circular muscles are contracting on a greater volume of muscle inside them. So this contracted longitudinal smooth muscles provide you an increased central filler volume. Now you can understand like this, that if I have to constrict my fist and generate occlusive pressure by a circular contraction, I need a lot of pressure, which is not possible for the thin circular urethral muscle to create. It can constrict, but it cannot completely occlude the urethral lumen. And imagine if it has in the center one pencil as longitudinal muscle, constrict, it still requires a lot of pressure. But if it has lots of fibers in the center and then it constricts, it can occlude the lumen by a very small contraction pressure. So the inner longitudinal muscles, by contracting inwards, give you increased central filler volume. And this has been understood very recently by us, and this paper came from Dr. Mistry group, a structured review of female functional urethral anatomy, with the emphasis on the role of urethral longitudinal smooth muscle, recently in 2019 in International Urogynecology. And this is, I'm talking of human beings. And you should remember that this smooth muscle compression provided by the synergism of both smooth muscles gives you 30% of urethral occlusive force. First 30% came by submucosal cushion. Second 30% is by the smooth muscle function. In the next lecture, which will be the lecture 4 of this series, I shall speak to you about the microanatomy and components of rhabdosphincter of the female urethra. So thank you very much for your patient listening. In case you have any questions or comments, you can write to me on my email.